So yeah, I'm gonna give the evidence-based medicine today. So it's gonna be a bit of a different structure. I pick a topic. I don't want to focus so much on what the paper is saying as the message of the paper, but rather more on the method, because I feel like the most important thing that we should learn from this experience is to learn how to interpret a trial. And that's going to be useful for someone who wants to do hospital medicine, family medicine, or in this case, oncology. So it's a skill that I think is going to be useful for everybody. So the topic is going to be about pancreatic cancer, but again, we're not going to focus at all on pancreatic cancer. It's going to be more about how to interpret a trial. So to those of you that like pancreatic cancer, I'm sorry, we're not going to talk about that a lot today. Okay. So just one thing also, I put some questions during the presentation. So there's not really, most of the questions don't really have a right or wrong answer. So please don't feel like there's something right that you're supposed to say. This is more to debate the paper, right? So you may have a different opinion than me. And that's actually better because like this we can discuss, okay? Because as you're gonna see, there is no, and one of the things that I want to show here is that there is no black and white in how to interpret sometimes, okay? And please stop me if there's something that is not clear. So we're gonna focus on how to interpret results when they are significant, but also when they are not significant. And the trial that we're gonna use as an example is called the Polo trial. And it's basically a trial of olaparib in patients that have metastatic pancreatic cancer, okay? I'm just gonna give you very few slides as an introduction, so at least you can know the context. This is the only thing we're gonna talk about pancreatic cancer, I promise, okay? So this is just so we can follow the topic. So, sorry, give me 1 second. I just want to put the pointer because I feel it's gonna be, here we have, okay, perfect. So so here we have, so this, the rationale on why they're testing this therapy in pancreatic cancer. So the main thing you probably all know about pancreatic cancer is that it kills almost everybody. So the 5-year mortality of pancreatic cancer, and this is data from this year, 2022, is 97%. So almost all patients that have metastatic pancreatic cancer are gonna die in 5 years. And because of that, there is a need of new therapies because the therapies that we have are clearly not working. Some of these cases of pancreatic cancer, a very small percentage, is around 10%, are due to having a BRCA1 or BRCA2 mutation. And 2 words about why that makes you have more pancreatic cancer. So you know that BRCA genes are involved in basically repairing double-strand DNA breaks, okay? So someone thought that, sorry, just gonna put this here, okay. So someone thought that these cells that don't have the ability to repair double breaks, if you also remove the possibility of clearing single-strand double DNA breaks, is going to lead to a lot of double-strand breaks. So basically, what olaparib is going to do in this in pancreatic cancer is create so many double-strand DNA breaks that the cells at the end are going to die. Okay, so this is the biological rationale on why we use olaparib, that at the end is not so important to understand the rest of the talk. So which patients did they choose for this study? So they chose patients that are, of course, adults and that have a germline BRCA1 or BRCA2 mutations. Just remember, you were the only one to test the therapy in this subset of patients because these are the ones where biologically makes sense to test this therapy. And of course, they have to have a confirmed pancreatic adenocarcinoma. And this is a very important condition. They have to receive 16 weeks of the first-line chemotherapy, that in this case is platinum-based. And after these 16 weeks, they have to have no evidence of disease. And they have to have toxic effects of this chemotherapy that have to resolve to a grade 1, or, SEC, alopecia, neuropathy, or somehow tolerable anemia, okay? So this is a very, selected population, right? So 16 weeks, so they have to be responding for quite a while, and they have to be tolerating treatment pretty well. So my first question to you, and anybody's free to answer, sorry. So how many patients do you think, so what's the percentage you think of patients that are gonna actually be able to be recruited into a trial? Do you think almost everybody's gonna get recruited? Do you think almost nobody? What do you think?
I mean, since the 5-year mortality is so low, and we know pancreatic cancer to be so aggressive, the fact that they're asking for no progression of disease after first-line treatment is probably going to be a really small population.
Exactly. Yeah, exactly. Completely right. So yeah, and exactly for the same reason that you mentioned, it's a disease that kills a lot of people, and you're already selecting for very, very good responders. And of course, if they die so early, it's because there are not so many responders. So just to put here what the authors found, like how many of the patients they screen and how many they actually managed to get into the paper. So you see that they screen. Oh, actually, I don't see it here with my Zoom, but I think it's okay here. So they screen around 3,000 patients, and at the end, they can only recruit 154. Of course, one key thing here is that very less than 10% had the mutation. But even from these 247 patients that had the mutation, at the end, they end up with only 154. So of course, many of them didn't respond because of what you mentioned, right? So it's very important to have into consideration. We're really dealing with a very, very selected group of patients. Okay. Sorry.
And it's sad too, sorry, Paulino, it's sad too that when you look at how even one of the exclusion was that some progressed while they were, even when they were getting screened in. So it's kind of sad also, just to kind of think about more of what we're looking at in terms of patient population.
Yep. Yeah, that's a very funny.
Yeah, 43 had disease progression or died, and so that's why they were excluded.
Yeah, no, definitely, that's a very good point. That also it's a pretty strict criteria of selection. Yeah. And so if we see here the characteristics of the patients, and I put here the figure of the paper, sorry, the table of the paper. I mean, I can briefly go through it. So basically, they are comparing you've probably seen that in many trials, right? So what we see, whether the population of olaparib and placebo were comparable, right? So which are going to be the two arms of the study. And as you see, most of the features presented here are pretty comparable between one or another one, right? Like maybe ECOG status is a 10, slightly different here, but to my from my point of view, I don't think there's many big differences. And I mean, if someone doesn't agree, you can tell me, but I think it's pretty comparable. And now we go to the intervention. So we talk already about which kind of patients they selected. And now we're going to talk about what did they do to these patients. So this is a phase 3 trial. It's an international trial in actually a huge amount of places and 12 countries. And patients were randomized to olaparib, 300 milligrams BID, or placebo. And that was done 4 to 8 I didn't put it here, for 4 to 8 weeks, sorry for missing that, after the last dose of chemotherapy. The study is double blind, crossover is not allowed, and they basically continue the intervention. So that is either olaparib or placebo. So that was continued until they saw progression. And the way they have and this is the same way that they have in all cancer trials, they have this criteria to evaluate for progression. So just one word on this. So you continue the drug until you have progression, or of course until you don't tolerate it. If you have someone that is basically having a 4-grade anemia, meaning that is completely the hemoglobin he's basically needing transfusions every day, of course you cannot continue the drug. But I thought it was very curious to analyze how they measure progression, because that's something we see in all the cancer trials. And this is basically, and you're going to read that a lot, done using the RECIST criteria. So RECIST criteria are basically a way that that all oncologists have to say when someone is progressing or not. Is based on CT scans, and you have here what is what. So complete response means that all the lesions that the patient had disappeared. Partial response, it means that there was a 30% decrease in the biggest lesion with no new lesions and no progression of other lesions. So here they basically make the difference between target and non-target lesions. I don't think we have to get into that, but basically is that you see a response that is pretty good, but is not as a complete response. Then you have stable disease that is basically you're not progressing and you're not you're kind of stable, right? You're not getting better, but you're not getting worse. And then you have progression of disease. That means that you have a more than 20%. So that's like, it's not that every lesion that gets better, you're already progressing. So it needs to be more than 20% compared to the smallest one in the study. And this is a trivia question, but does any of you know why it's 30% and why it's 20%? Like why is not 50%? Why is not 100%? Why are these numbers chosen? And this is a very trivia question. Is not something you need to know, but it's just, you know, I think it's actually cool to understand where these numbers are coming from.
Maybe it's from the speed of pancreatic cancer cells growth, or like.
So actually, so that will be a better answer. So I hope that would be a reason what you mentioned, because that makes biological sense, right? So based on what you said made a lot of sense. So based on how the cells divide, sorry if I didn't explain that well. So RECIST, these criteria are for all solid malignancies. So it's not only for pancreatic cancer, but it's still what you say made a lot of sense. So it will make sense to make this based on any biological features of the cancer. But reality is that the reason that we're using the RECIST criteria and the reason why they pick 20% is because and this is not a joke. So in the 1970s, one oncologist invited other 12 oncologists to a party, and they play again. This is, you can actually Google that. This is true. Where he wanted to know, just with your blind eye and touching a surface, how can you know how big does a ball need to be for you to realize that it's bigger, right? So basically he invited 12 of his friends that were also oncologists, and he basically put a sphere, I think it was under a tissue of rubber, and he made them touch the sphere, and he used different sizes of sphere until they realized, and and he basically tested to see what was the size, how much bigger did the sphere need to be for someone to realize that it was bigger. And they realized that in order for someone to realize that the sphere has gotten bigger, it needed to be twice the size, so much more. And that is, of course, in 3 dimensions. So if you put that into 2 dimensions, you get the 20% here, because it's a sphere and it's a diameter. So what it means is that this is not based on anything that has to do with a CT scan. Anything that has to do with biology is a purely arbitrary measure. And it's also important when we interpret that someone progressed, which is important to know that it progressed, but it's important also to know that the cutoff that we pick for that is very, 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 it's actually based just on that. So it's not really based on any biology. But yeah, sorry, other than that, we can continue probably with the trial. So the patients, so we're going to talk now about what was given to every patient, okay? So the patients, just to remind you, they first have to get platinum therapy, and they need to be responding to platinum therapy. And after that, they were randomized to either olaparib or placebo. And I want to get your opinion. So would you have designed the study like this? Would you have designed it in another way? Does someone have any other views? Or maybe someone will say like, oh yeah, I think it's a good design. Or someone thinks, oh, I would actually have done it in a different way. See, everybody's very shy.
I think the fact that they start with a narrow selection criteria, maybe they're trying to find any effect at all for this medication. And if this one is successful, they can broaden the study subject later. Sounds like a smart way to approach it if you want to find an effect.
I agree with you. Would you have done it like this, or would you have done it? Would you have changed something? Or if tomorrow you have to do this trial, would you do it the same, or would you maybe pick a different kind of patient, or would you have changed anything of the intervention?
I think I would have changed a little bit. I don't see why they first started with patients who have already responded to first-line therapy, and then after that they placed them in 2 arms, olaparib and placebo. Wouldn't have be better if they have just started right from the get-go with olaparib and placebo?
So I tell you, the argument that the authors use for that is because they think the therapy is good for maintenance and not for treatment. That's the argument they use. I'm not giving any opinion. I'm just saying that the argument of why that happened is because of that. Because they think that this therapy is going to be good for maintenance, but not for treating.
And what did they like define the criteria of like patient with now maintenance like therapy? Like, is there like a absence of like disease, or like what do they mean by like?
Sorry, you mean that how they pick the patients that are responding? Is that your question?
No, like, so if the patients are responding and now they want to place them on maintenance therapy, like what would the definition of patient who is now done with the like initial treatment and then
This is a very good question. So there's not really any definition of you're done with platinum. You can give and you hit a very important point. So you can keep treating as much as you want.
and it's not
Oh, you mean right now there's no standard of care?
It is a standard of care, but the survival is 1 year. So you can, the only thing that prevents you from treating is toxicity, but you can keep giving, and I've seen patients getting FOLFIRINOX, which is the first line, for more than 1 year. It's uncommon because at some point your body's not going to tolerate, but you can make breaks, you can play around, you can reduce the dose, but there is not such thing of, oh, I only give you 6 months or 6 weeks of FOLFIRINOX and then we're done with FOLFIRINOX. You're done when you progress.
But Paulino, like Eric and Nora brought up a good point, because when you look at the table, like the characteristics, the last two like variables that they looked at is like table 1, the baseline characteristics. Like when you go back, that's the question I had, because when you go down here, duration of first line chemotherapy before randomization and meet the new age, I was just like, that's a very crazy range of like the patients, like in general, like there was, like how long were these patients on even the first line? And could that have been something a little bit more stricter? But again, we're talking about pancreatic cancer, and it's like a completely, and I know that they're just trying to also get a sample, so they're trying to get patients. But that's like what, I think Erica and Nora kind of like even pointed out, is like, this range, and it was kind of interesting how wide it is, and even the 35-month and the 20-month, and how they were even included in this type of thing. But again, I kind of understand the background, but I don't know if you had any other input into that.
No, and I think you're all hitting a very good point, and I actually you definitely hit on that good point. That is that and I'm just putting here some criticism of that other oncologists had on this trial, is that if you have a patient that is responding to FOLFIRINOX, why would you stop FOLFIRINOX? So to which point is ethical and okay to give, because half of these patients are getting placebo. So, well, not half, because it's 3-2, but a third of these patients are getting placebo. So a third of these patients were responding to FOLFIRINOX, they stopped, and they were given placebo. So a lot of people consider this a strongman comparison. So, so that means that you're testing a treatment against something you will never do, because a lot of, and you can actually find this online, and many oncologists criticize this trial because what they say is that, you're comparing olaparib against something that is not real, because nobody will ever treat a patient with placebo especially after responding to FOLFIRINOX. So he's responding. So that was, and I think you all hear on a very good point that why did they stop giving FOLFIRINOX? So that is actually a very good critique to this to this trial, and I'm really glad that everybody jumped and saw that, because I, for example, when I read the trial, I didn't realize. I was like, okay, fine. And then after seeing the reactions on people, I said, oh my God, I missed it. Like, how can you treat with placebo with someone that was already progressing, right?
Is this the reason why they randomized the trial 3-2? Because I was wondering why 3-2.
So this is based on the power calculations that they did. So based on how much I didn't enter in these calculations because I didn't want to put any numbers, because I feel like I also get scared when I see a lot of numbers in but it's basically made in a way that you calculate how much power, so how much difference you expect to find and how much you want to find. And we will get into that a bit later. And based on that, they thought the best, you say like, oh, I think this treatment is going to give a 20% improve in hazard ratio. So based on that, you see how many patients you will have to randomize in which place to get this. And also it's a bit also of the variation you expect in the control group. If you have a control group where survival is going to be from 1 to 20 years, you need a very big control group. But in pancreatic cancer, they're all going to die, unfortunately, in 1 year, and most of them are going to die in 1 year. So the variance of your control group is very small. So, and we will get into later why this, why variance is so important here. But because of that, you can make a control group that is very small.
But that's a great question, Fatma.
Did they talk about why they didn't want to do a crossover in this study? Because I would also think that if you have a very limited amount of time, you might say, okay, after 3 months, if the people who are getting placebo were not doing well or had advancement, maybe we would try olaparib.
I think that's a very good question. They don't mention that in the trial. I think the reason is because if you allow crossover, interpreting overall survival is going to be difficult, because most patients with pancreatic cancer are going to switch to whatever because there's nothing. So they may be, then you end up having a control group where a third of the patients got olaparib. So it's a bit difficult to interpret, but that's my speculation. They don't really mention anything, and maybe there are other reasons that I don't know.
No, and you're correct, because then you're decreasing the numbers, and then you end up causing a lot more noise, and then your sample's already small, that then even the power and the effect that you're looking at may not even be, like, can you even say anything about it? It's a nice thing to do in the future, but it's just hard because the numbers for what you're looking at, which is pancreatic cancer and the patient population.
Also, it wouldn't really
Go
with the primary endpoint, because our primary endpoint here is recurrence or side effects. And then if you want to do crossover, there has to be like a time endpoint or something. I don't know. That's what I remember, at least.
You mean that you need a washout period, and that's also another thing. Like if you need a washout period and your survival is 1 year.
I think it's a challenge with what you're looking at, pancreatic cancer in particular.
Plus, I would say also they were developing or progression, would you even want to give this medication as opposed to platinum therapy as well?
Yeah. Good point.
Very good point, yeah. Okay, so we talk about the interventions, and just to put it here a bit of what happened on the intervention. So you see that at the end, as we mentioned, it was a 3-2, so 62 got placebo, 92 got olaparib. And if we see here, most of the ones that were assigned to get placebo got placebo, except one that they found later that he was not meeting eligibility criteria. And 90 out of 92 actually got olaparib. So it was only one that withdrew consent and one that did not meet eligibility criteria. And we will continue talking. So just see how olaparib was tolerated. You will see here, it is actually very important to see the side effects. And I felt like every time I used to see these tables, they look the same to me. And say, oh, diarrhea, yeah, of course, everything gives you diarrhea. But I want just to draw your attention on grade 3, because you're going to see in some, especially in these new cancer therapies, some of them have actually, which is not the case of olaparib, but just to illustrate how important this is to see this when you see the trial. Some of the new ones, especially in breast cancer, have a very, very high incidence of grade 3 diarrhea, and you can actually have patients dying because of diarrhea, which happens. It sounds like, but it happens. Even though these are all normals, I think it's very important to see which ones were grade 3, which in the case of olaparib, to be honest, as we can see here, and you can see here the difference between olaparib and the rest, probably the main thing that we see is anemia in grade 3. But other than that, it seems to be relatively well tolerated. At least that would be my take on this. And then let's start talking about the endpoint. So imagine you are the one designing the trial. So we talk that we have olaparib versus placebo. So which readouts, which clinical endpoints do you think are relevant? So which one would you choose?
I would personally go for POD, progression of disease. So whichever way I decide to measure that, either with a PET scan or with the interval clinical examination to see the progression of pancreatic cancer and metastasis.
Okay, so you will choose progression of disease, okay? Someone will choose anything different?
I think both are important.
Sorry, what did you say? I didn't hear that.
I think like both are important. We can't take both.
Yeah, you can do more than one. I mean, you can do survival, you can do progression of disease, you can do whatever you want. You can do as many as you want. Okay, so this is very similar to what they chose. So they chose, their primary endpoint was progression-free survival. So progression-free survival is a composite, okay? So it means two things. So you progress if either you die or if you progress by radiological RECIST 1.1 criteria, the criteria I just told you about, okay? So this is progression-free survival. And they chose some secondary endpoints, overall survival. So basically how much do you live, regardless of why. Second, progression-free survival, so meaning that you progress and then you progress again, which the only difference here is that it can also be symptomatic progression, which is a bit, but this is actually very not so common, but they chose it still. Quality of life, which actually surprised me because I think this is very important. If you have patients that are not going to live, even if they're going to live long, I think this is so important. We often overlook that in trials. So I was very happy to see that they actually measure quality of life. And also they have objective response rate, which is basically another composite of progression and change in quality of life. So basically, if you're either responding or have an increase of quality of life, you have a response. Okay, so these are the ones that they pick, and the main one is going to be progression-free survival. And we will go later to see whether we think that was a good decision or not. And now let's talk about the monster, the statistical analysis. So the data on efficacy. So which population they picked to analyze the data on efficacy was an intention to treat. Okay, as you all for sure know, intention to treat means. Anybody wants to say what it means?
The originally selected population, regardless of who was excluded later. Or something like
Exactly. Very good. So it was exactly. So the patients that were randomized, regardless of whether they end up getting the therapy or not. And then the data on safety is actually a different population. So these are all the patients that at least got one dose of the trial agent. Because of course, like if you got randomized to olaparib, but you didn't take olaparib, doesn't make any sense to check for toxicity, right? And progression-free survival, overall survival, and second PFS were analyzed using the log rank test. And in the next slide, I'm going to explain these two tests just in case someone doesn't remember, okay? And that's what Fatma was mentioning before. So that is the power. So they calculated for 80% of power of hazard ratio. So they want to detect a hazard ratio of at least 0.54 using 80% of power. So they have 80% of power to detect a difference of 0.54 in progression-free survival. Okay, so when they make the calculations of what was the difference that they wanted to find, they used PFS. Okay, they didn't use overall survival. And for the subgroup analysis, they use the Cox proportional hazard model that I'm going to explain in my next slide. They use a score for the quality of life, and they also evaluate for multiple testing procedures. So, and the reason they're doing that is basically if I test for 1,000 things, of course, something is going to come out positive, right? So if I put 1,000 readouts in the trial, one of them is going to come back positive, right? So the way they did to go around it is that they calculated the PFS because that was progression-free survival. That was the main objective of the trial. And if that came back positive, then they calculated something else. Okay.
Paulino, can I ask a question?
Of course.
So for the calculated 80% power, is this hazard ratio 0.54? Does this mean that this power, you have 80% of detecting this effect size if it is 0.54 hazard ratio or higher?
Yeah. So that means you have an 80% power to detect a difference that is at least 0.54.
0.54. Is that considered significant? That's a lot of, like, that's almost half, right?
It's almost half. And actually that, you can lead me to my next slide, which is the definition of hazard ratio. But yeah, as you said, that's almost, there's actually a strong effect. That doesn't mean that they only want to detect such a big difference, right? So they may happen to detect something smaller, and I think actually they end up detecting something smaller. But your aim is 80%, which again is difficult in pancreatic cancer to go a bit higher, because you don't also, especially in this population, right? So just to mention, and actually you brought a very good point of what is hazard ratio. So what does this actually mean? So remember, we're calculating survival and progression-free survival using a long RUC test. That's the one you see in every clinical trial, which is basically a non-parametric test, very used for survival and for Kaplan-Meiers. And the reason is because it deals very well with skewed data to the right, because people are dying, right? So your curve is not going to be a normal distribution. It's going to be skewed to the right because people are dying, right? And with sensor data, remember, some patients, you don't see them dying, they just lose follow-up, right? So these patients you censor, but you still want to include them in the data because maybe you were observing the patient for a year, right? So this test is very good to deal with these two kind of problems that you see normally. So that's why it's used so frequently. And it's going to give you a p-value and a confidence interval and a hazard ratio. And just to remember, what is the hazard ratio? That's the chance of something occurring in the treatment arm divided by the chance of something occurring. And when I say something, it means either progression if you're measuring progression-free survival, or death if you're measuring overall survival in the control arm. So if a hazard ratio is 0.5, you basically are seeing a 50% reduction in death just because of the drug you're giving, okay? And the Cox proportional hazard model, it's also the one you see in every trial when you want to see, when you have 5 different things affecting something, right? So when you want to do a multivariate analysis, when you have a lot of different things that are affecting one thing, so then you want to see where is coming from, which is coming for what, okay? You're going to see that probably clear when I show you the table, because I feel it's very difficult to explain if you don't have a clear example. But this test is basically used when you have many things that can affect one outcome, and you want to know which of the 20 things that could affect it was the one that actually did it. Okay, and now let's go for the results. So these are the results on progression-free survival. So you see here in red, patients that got placebo, and you see here in blue, patients that got olaparib, okay? And this is the probability of survival, okay? So this is a bit like a Kaplan, it's actually a Kaplan-Meier, but with a progression-free survival, okay? And just to see here, the hazard ratio for actually is 0.53, sorry, with a p-value of 0.004. And if we compare the median PFS in olaparib is 7.4, and in the control arm was 3.8, okay? And I want to now make a kind of a bit to focus on how do we interpret when something is significant, because it seems that, oh, it's significant, good, we take it. But it's sometimes, you know, more difficult. And for that, the first thing I want to, and this is just one slide to get a good statistical background, just to make sure when we see this p-value, what does it mean? Just to remember, we're using a frequentist model. So that's where you see most of the trials, but there's also other model called Bayesian that I'm not going to get into it. But the frequentist model of the p-value confidence interval have a lot of limitations, okay? Because the p-value does not tell you the probability of something happening. And this is very important to know, okay? If you want to know the specific probability of something happening, you have to go to the Bayesian model. And you're going to see actually Bayesian is actually getting more trending in some trials, but you need to understand that this is not the probability of something happening. You have here the definition of a p-value. So it's basically probability of obtaining a result that is at least as extreme as observed if you assume that the null hypothesis is correct, which is much more complex than just this. Okay, and because the p-value does not tell you the probability of something happened, the confidence intervals don't have 95% of containing 95% of chances of containing the true value of interest. Okay, because it's basically the same thing. If you want that, you need to go to the Bayesian model, which is a different model. And if there's something you have to take from this slide, I want it to be this. So this model is affected by 3 things: how big is your size, right? So how big is the difference that you actually see? So if you have a treatment that is prolonging survival 10 times, so this is of course going to affect, but also the variation. So if you have groups that are very, very different, so if within a group, you have people that live, and that goes back to what Fatma was asking before. If you have groups that live 1 year or 10 years, that's actually going to reduce your p-value, because difference between the group, among the same group, increases your p-value. So it's gonna be more difficult to find a difference. Okay, so you want your groups to be homogeneous to have a better p-value. And of course, sample size. If you have very big samples, your p-value is going to be very small. Okay, so this is very, very important, because all these things are going to depend. You can see, and we're going to see examples of that. Your p-value depends a lot on these three things. Okay, and just to remind you, the frequencies model does not integrate prior knowledge. So whatever we knew about pancreatic cancer before doesn't matter. This is different to variation. In variation, it matters. Okay, so now that I'll talk about that, and we saw statistically significant results. Do you guys think that every statistical significant result is clinically significant? So in other ways, in this situation, is there any other situation you can imagine where you will have a statistically significant result that is not clinically relevant? Or do you think it's always?
Like
it can happen.
Sorry, what did you say?
Like there can be a possibility where you can find a statistically significant result, but then it's not clinically relevant, because the percentage, it's so small that at the end, if you have a large number of patients, if only 0.05% will benefit of it, then there is no point on the medications, because a very, very, very small number of the participants will benefit from it.
Yeah, that's actually exactly. So you hit it exactly. So not every clinically significant, not every statistically significant result is going to be clinically significant. One possibility is that very few patients benefit. Another possibility is that the effect that you see is very tiny, but you're so, as you rightly said, Christopher, you're so overpowered that you can detect tiny differences. And I'm going to give you one example of that in pancreatic cancer. So this example, this is another trial, okay? I don't want to confuse you. This is the only slide you're going to see from a different trial, but I thought it was a very good example. Where they compared, this is another trial, okay, where they compared gemcitabine versus gemcitabine and erlotinib in the same population, patients with metastatic pancreatic cancer. And just to remind you, our trial had 154 patients. So here they enroll 569. It's almost 5 times more. And look at the curves. Okay, so you see the blue is the erlotinib, and they say that is, and it was actually, I didn't put the p-value here. Wait, did I put it? Oh yeah, I put it here. So you see it's a p-value of 0.03. It's significant. And so, but if you start to see at this, look at this, the median survival for placebo is 5.95 months. And the median survival for erlotinib was 6.36 months. In other words, erlotinib improved survival by 10 days. And it was significant. And it was actually FDA approved. That of course happened in 2007, so it's a bit it was a bit earlier, but here is a very good example of a trial where you overpower, so you use a lot of patients, you can detect tiny differences, but a lot of oncologists will tell you that this is not clinically significant, right? Because it's 10 days. I mean, and this drug is actually, erlotinib is actually very expensive. So it's not, even if it's significant and even if it was approved, it's not something you, at least some people wouldn't use it, right? So I want you to understand that if you have a big N, you can power the trial to detect any tiny little thing, but that doesn't mean that that's relevant, okay?
No, and the thing is, sorry, Paulino, just from this example alone, I was going to say even from the insurance perspective, because the problem of a lot of the oncology drugs is cost. And cost is always going to be something more from the clinician perspective. You know, when are you advocating for your patient? And when you look at the study, are you going to be able to say, look, like I can justify the 3 times more money for this medication versus not. And you as a clinician, you can, or someone who could critically place it, you said you can kind of play it both ways, and honestly, you can kind of say, no, not really, because we just kind of said, look, like this doesn't look really clinically significant, but that's more of like the real practice when you're trying to get these new drugs that are FDA approved recently, your patient's going to come in and say, hey, look at this. And you can look at this graph and they could probably explain this to a patient. But in the end, it's going to be like those things that you weigh, and in the end, it's going to be the insurance. And are you going to even be able to get it approved for them to be able to get it? So go ahead. Sorry to cut you off.
No, definitely. That's a very good point. I mean, at the end, also I'm sure this drug is a fight with many insurances, and I can see why, honestly.
And I think, Paulino, it's also like there's other factors that can interfere with clinical significances, like side effect profile of this medication, quality of life for the patients, and as Dr. Osario said, also the financial burden.
I agree. This is actually a great point. In a Kaplan-Meier, you don't see all the, I mean, there's more figures of the paper, right? So there's many more things. There's even data that doesn't show up in the paper. So I agree with you. I mean, I completely agree with you. And I think also it stresses the point that not everything, a p-value is not everything, right? There's many more things to decide before we decide if we give the medication or not. So going back to this slide, where this is the previous slide I will show you of the progression-free survival. So they did a subgroup analysis that you see here. And one thing, I mean, they don't really find great things in this subgroup analysis, but one thing that I thought it was interesting is that they said it was pre-specified. Why do you think it needs to be pre-specified? Why they can not just do whatever they want? What do they need to say before?
I think it helps with what is it called? Analysis
Confusion.
bias. Yeah.
Like confounders.
Well, it's not so much of confounders. It's like, again, is the multiple testing hypothesis, right? So if I test every single subgroup, at the end, something is going to come up positive, right? So if I have a drug that doesn't work, but I do a subgroup analysis of every single thing, at the end, something is going to come back positive, right? So the reason why it needs to be pre-specified is because before running the trial, I'm already saying I'm going to check for 5 things. But then if the paper comes up and you see that I check 1,000 things, you're like, oh, this guy has been testing everything until he found a p-value, right? So that's called a p-value hacking. And that's why it's so important for you to specify what you're going to analyze before you analyze it. Okay. And do you know where you can find if that was pre-specified? So you find it in there's something called study protocol. That is actually something very important in every clinical trial. That is something that you write before you're going to do the trial. So you say, I'm going to compare this group against this other group, and I'm going to check for this, this, and this. And it's actually sometimes funny to see the protocol and compare it to the actual trial, because sometimes you see that along the way, some things were changed. And that's actually also a way to know if the quality of your trial is good or not. Okay. But now, just going back to the data on PFS, will you guys approve the drug or not? Put you the data again, if you want.
Personally, I would not approve the drug.
Oh, why not?
Because from the chart that you showed earlier, it showed 40 patients from the treatment group were excluded because of disease progression, and that number was about the same on the placebo group.
Well, yeah, but also the placebo group had less patients, right?
Yes, had less patients, but they had the same number. So,
well, I mean, yeah, I mean I think like from a PFS, and that's just my opinion, right? Like everybody can, I mean, percentage-wise, in progression-free survival, the placebo group had a very good response. I think the problem of the trial comes here, that's the overall survival data, right? So remember, they had multiple readouts. The first one was progression-free survival, like how the tumor was getting bigger or smaller. But here is whether patients live longer or not. And we see here the patients that either they took olaparib or placebo, they lived the same, right? There was not really any change.
So did you catch Finn? She wrote that right before. So if you look at the chat.
And then but I thought also it was actually interesting because there's a lot of people that love to, I mean, you're going to see very frequently this in the press and everything, that they're going to make a lot of arguments about how to interpret when the p-value is negative. And I thought that it was actually interesting to understand how to interpret things when they're negative, because it's also as important, right? So, and the key question here is that, is this lack of significance because there was no effect or because they didn't have enough power? And here power is even a bit difficult to understand because they power the study based on PFS, right? So they didn't power it based on overall survival. And remember how important power calculations are. Remember the example I gave you with the erlotinib. So if you overpower the study, you can see anything. And also remember, this is a clinical trial, but when you guys do a retrospective, which I don't know why I put retrospective twice, sorry, but if you do a retrospective study, you have no control over how many patients they're going to include, right? So you don't control the sample size, but these guys are doing a clinical trial. They control that and they can power that. So this is where it's very important. Did I have enough power to detect a difference or not? And you can probably even run these calculations in overall survival here with this patient. I didn't do it, but you can probably do it, right? So a lot of people are going to say, well, but maybe there is a difference, but you actually can run calculations and see whether they have power to detect it. And even one thing that I thought it was very interesting, and actually Rafa gave me a very good article about it, interpreting the confidence intervals is actually very important to understand these non-significant results. Because remember, we talk about one thing called minimal clinical important difference, right? So there is one threshold where it tells you whether you think something is clinically relevant or not, right? So we said that maybe living 10 days more is not clinically relevant, but maybe living 1 year more, it is relevant, right? So one thing that this publication was suggesting is that you can actually say, okay, for me, it's clinically relevant to live more than 2 weeks or 3 weeks. You put a threshold, and then you see where your confidence interval lays on that. Okay, so imagine we say that for us, less than 3 weeks is not clinically relevant. Okay, so you can say 3 weeks will be here and 3 weeks will be here, right? So you can kind of, so of course you have to translate that to a hazard ratio. So that's a bit annoying, but let's say a hazard ratio higher than whatever, so higher than 8.6, 8.8, 0.8, sorry, is relevant, but anything in the middle is irrelevant. So I don't care. So if you have an interval like interval A that goes in the middle of things that are irrelevant, you're pretty confident that things are going to be irrelevant anyway. So even if you overpower the study, it's irrelevant. If you see interval B right here, so it may be meaningful benefit, but it's definitely not going to harm you. But then if you have like interval C, you just don't know. You need more power. And just to give you a practical example, so imagine we have a confident interval of something that is not significant that goes between 0.3 and 1.2, okay? And our minimal clinical, our threshold for benefit is 0.7 for benefit and 1.3 for harm, meaning that a hazard ratio higher than 0.8 for us is worthless. Like this is not really a benefit that I care about. And any harm less than 1.3, we're okay with it, okay? And then we see a confidence interval that goes between 0.3 and 1.2. So that would be kind of the situation B, right? Because the 0.3 is actually really low. It's lower than 0.7. So it's probably meaningful. So there is a chance that this therapy, even if it's non-significant, there is a chance that it's either beneficial or irrelevant, right? Is probably beneficial, but it's definitely not harmful, okay? So interpreting this confidence interval is key to understand and to make speculations about a non-significant test. Okay, so going back here, we see that the confidence interval was 0.56 to 1.46. So unfortunately here, I mean, again, everybody may have a different threshold, but it's actually pretty broad. So probably we cannot make any conclusions here, at least in overall survival. And also just to mention, there was no change in quality of life score in this trial. Okay, so quality of life and overall survival were the same. There was no change. So just to conclude, In this study, we showed that it shows that patients with metastatic pancreatic cancer with a BRCA1 or 2 mutation, olaparib increased progression-free survival, but there was no change in overall survival or quality of life as compared to placebo. And just to tell you how the story ended up, this drug was approved at the end of 2019 by the FDA for exactly this indication because of this trial. And nowadays is commonly used. You may have seen a patient taking it, and it costs around 7,500 per month, which is actually something pretty, something that we have to have into mind. So what do you guys think? So would you have approved the drug? Who thinks it's worth to approve the drug? Who thinks this drug is not good? What do you guys think? Is anybody has any strong opinion on both sides?
I stand by my comment. No.
Yeah, like if there is no change in the quality of life and there is just progression-free survival, but there is no change in the overall survival, then why spending $7,500 a month? No difference. I wouldn't.
Okay.
I think so. The question that I have: how do we have progression-free survival but similar quality of life?
No,
Is it like the side effect profile? What's going on?
That's a great question. So the thing is that progression-free survival correlates poorly with quality of life in some cancers and correlates poorly even with survival in some cases.
Yeah, this is one of them.
yeah. So it's not. It's. I mean, it looks. It doesn't. It looks weird, right? But that's how it is. Like the data shows very clearly that the correlation is not good in many cancers. I don't remember now on the top of my head how it is for pancreatic cancer, but in many cancers, the correlation, because at the end, we talk about it, right? So PFS is the threshold is very arbitrary. Why 30%? Why 20%? And sometimes, especially pancreatic cancer can give you cachexia. So can give you actually a lot of systemic symptoms. But maybe that is not so much related to the size, or is not only the size, right? So maybe there are more things that we don't know about the biology, but it's definitely not a one-to-one correlation.
I also wonder because olaparib is like a tablet you take every day, and I guess if the people on the other side on the placebo were taking this tablet every day, they probably weren't on chemo. But I would wonder if they compared being on like chemo versus taking this, the quality of life would have been different, because I guess that's the only benefit of the olaparib.
So actually, you brought something that I was actually discussing today with Rafa about how. What is the argument that some oncologists gave to approve the drug? Because the approval also was very tight. It was 7-5, 7 in favor, 5 against. And what many oncologists were saying is that, well, but at the end, we're giving a tablet and we're not giving chemo. But as you rightfully mentioned, in the trial, you're not comparing against chemotherapy, you're comparing against placebo, right? So yeah, it could be, that maybe you compare against FOLFIRINOX and maybe you don't have a difference in survival, but you have a difference in quality of life. That's possible, but they didn't do it, right?
Because I guess that's the thing because me and Paulino both, and Michelle and a few others, we go to Prof. O'Reilly's clinic, who I think was involved in this trial. And I think the patients that are on olaparib are like very well, and they're like coming in, and some of them are working, and this kind of thing, where the people that have the chemo, like a lot of them are much sicker. But I guess you can't see that in this trial. So then I'm not sure.
No, I agree with you. I think it will have been great that they tested against FOLFIRINOX, and then you can see that, and it could be. I mean, I agree with you. From the patients I've seen there, I think it's a possibility, but they don't really show it, right? There's also the argument. Sorry, yeah.
I'm really surprised, like in the original design of the study, why didn't they include a FOLFIRINOX arm or like a chemotherapy arm? It's just annoying.
Do
you think it has to do with who sponsored it?
You
didn't mention that, Paulino. One of the limitations is what?
Yeah. So I mean, that also could be who makes FOLFIRINOX, right? And how, I mean, it's difficult to know why, because at the end, these trials are normally not designed by the investigators, are mostly designed by, it's mostly AstraZeneca here and the pharma company. So there's not really any transparency on why it was. But it's true, for example, Dr. Serra was mentioning that sometimes if you don't want to randomize, if you don't have the patent for FOLFIRINOX, you don't want to randomize things against FOLFIRINOX, because you have to give your competitors drug, right? So it's
I am surprised it did get approved because I wish that they would be able to kind of do a future study, but it's just, to get their approval. But I also understand that some of it has to do with what we're treating and just needing basically treatments, like you mentioned from the very beginning.
The problem though is it's great that it got approval, but we as a country have to look at all of these new chemotherapy drugs and hem-onc drugs. They're great, right? And all you people going to hem-onc, you love to give these drugs. But from a country point of view, is it really worth spending $7,000 for someone to get them a year when we don't give 40 million people health insurance, right? And I think in this country, no one wants to say that. And nobody wants to not give drugs to their mom who has a horrible cancer and they want to get a few more lives with her. But at some point, someone has to decide, how much do we want to spend on end of life care for people if it's months, right? Even if they're good months, there's a cutoff.
Yeah.
And does everyone have equal access? They don't. And that's where, is the difficult conversation in this country and around the world,
And
in this country.
And Paulino, not to put you in a place, but you will be moving from New York to a very special place called MD Anderson. And you'll kind of see what this was just brought up right now. And so that's just a lot. The good thing there is they're very good about doing clinical trials and allowing county insured patients to be enrolled in these studies. But this is where that's coming from when you see that, like the discrepancies that you're going to see just in the same country, but a different location.
I think one thing that I found recently and it shocked me is how the FDA approved is different to other agencies. So for example, in Europe, I think also in Canada. So when you approve a drug, you're not only approving the drug, you're also saying if it's cost benefit. So you also, the European drug agency has the capacity to say, even if this drug is effective, they want too much, the price is not affordable, we shouldn't buy it. And then of course, every European country can do whatever they want, but you give a recommendation against it. And one thing I learned recently is that the FDA is not authorized to comment on any cost. So all you can say is if it's effective or not, but you cannot, they don't have the right, the power to say, it's not, it's even if the drug gives you 2 days, 10 days, like erlotinib of life, the price that they want is too much, we shouldn't buy it. So I think that's something that maybe could be implemented. And I think actually some people in the FDA would like to have that power to be able to comment also on the price, because as Dr. Andrelli mentioned, it's and Dr. Osorio, this at the end gonna impact all of us, right? And we have to think as a country and not as individuals if we want everybody to be to have access, right? But that's a difficult discussion.
Yeah, I don't think that's like the difficult part. We all agree on that. It's just making sure everybody agrees with us. Like insurance trumps all at the end of the day. Sorry for using the word Trump.
Yeah, that's what I was about to say. No, but because I know I'm looking at the time, I just want to first comment that, this was an excellent presentation, Paulino. We have not held an EBM session, I think in about a year and a half now. So I think this was really excellent. It was really nice to have you present as our inaugural coming back, and Raf for really just trying to incorporate this different style. And again, any feedback is appreciated because we, as Paulino mentioned from the very beginning, we're trying to kind of tweak it around and kind of learn basic stats while we're doing some critical appraisal of the article, but really focusing more on like the statistical kind of like basic, just what is the confidence interval, what's a p-value, and kind of tweaking it around a little bit. Okay, thank you guys. You guys did excellent, or Paulino, you did excellent, great discussion.
Thank you so much.
Okay. Thank you so much, Paulino. That was amazing. Thank you for all the meaningful discussion.